Okay, I'll just start again. Welcome everyone to KHealth January speaker series. We're so excited to have you here tonight. So my name is Peter, as Justin mentioned, and I'm one of the ICHP coordinators this year, along with Brittany and Ashita, who are also on this call right now. And what the ICHP is it's an interprofessional program that we've designed this year with a combination of online modules, speaker talks, and also other case competitions and case studies, where you're able to gain a certificate at the end of the year if you complete a certain amount of those components. If you're interested in signing up for the ICHP, I'll post the link in the chat here. And that's just a link to the Google form to sign up, and more information will be provided you on what sort of components need completed once we receive your sign up, and then we can talk more about that afterwards. So without more ado, I'll pass it to Justin, who'll introduce our two speakers for tonight.
Awesome, thank you so much, Peter. So again, hello everyone. Welcome to the January edition of the KHealth Speaker Series. So the title of today's talk is how to manage your own risk of empathetic strain, overload, and secondary trauma. So again, we're truly grateful to have not one, but two speakers for today who have graciously offered their time to speak to us. So just as a quick intro, Françoise is a registered psychotherapist, much sought after public speaker, educator, and has over 25 years of experience as a mental health provider, helping individuals who work in high stress environments. Françoise is also a former TEDx speaker and author of the Compassion Fatigue Workbook, which was published a few years ago, as well as Tom Doulas, who has been a physiotherapist for over 13 years and is currently working at the Chronic Pain Clinic at Hotel Dieu here in Kingston, and is also very knowledgeable on the subject matter of secondary trauma and burnout. So again, thanks for joining us today, and we'll give everyone a warm welcome, and I will hand it over to Tom.
Thanks, Justin. And thank you guys for having us. We're going to talk about what some of the natural consequences are of working in what we call a caring profession. So I understand there's a lot of medical students, maybe some rehab students, nursing, all these what we call caring professions, anytime we're giving care to other people. I met Françoise many years ago now. She gave a talk similar to this when I was at one of these Queen's clinical supervisor appreciation dinners. And I remember this night so well. Everything she talked about that night, I felt like this woman was inside my head. I felt like I was working really hard in a career where I spent a lot of time, money, energy, trying to get really good at my trade. And instead of feeling happy and fulfilled in this, I found myself feeling angry a lot of the time and resentful. Hearing Françoise talk that night is the first time I actually heard someone put words to what I was feeling. For me, it was just anger and frustration most of the time. Some of my strategies would be, I'll go do some professional development, or I'll go do a course. And of course, they were never in Kingston, so I'd have to take a weekend, which I really valued, and I'd have to travel to a bigger city, Toronto or Ottawa, and go do a course. And if I didn't learn enough, I came back more frustrated. My go-to strategy for feeling kind of rejuvenated actually was now making me even angry as well. This continues to be something that I'm really passionate about, and something that I actually make a priority in my practice. So I get to stay in a profession that I love for a really long time, because I was drawn to it for a reason, and I want to stay here. We talked about different terms already, things like compassion fatigue, empathic strain, vicarious trauma, burnout, secondary trauma. This is where I like to pass it off to our expert. Françoise Mathieu, she, like Justin said, kind of wrote the Compassion Fatigue Workbook. She's a sought after educator in the field, the executive director of 10 I was hoping Françoise could help us kind of clear up, what do these terms exactly mean, and what are the differences between the different terms? Because for me, I can kind of pick, sometimes I felt this and sometimes I felt that. And for me at the time, it was just all felt like suffering.
Okay, thanks, Tom. Let me jump in here. Let me give you, I'm going to give, well, first of all, good evening, everybody. I've been on Zoom a lot this week, like you probably have too, but I taught this morning in French at an interdisciplinary all over Ontario kind of presentation. Yesterday was the OPP 911 dispatchers, communicators. And the day before was Kansas. So I've been all over the world sitting in this chair this week. So I want to give a really short history background to how the terms evolved, because there is a lot of confusion out there. And I'm sure you've all heard the word burnout. Burnout is the umbrella term, particularly those of you who are in medicine. I have a bone to pick with the fact that physicians use the term burnout as the umbrella term. I disagree with that, but we could have a longer conversation about that some other day if you want. But the really short version is that, as many of you know, the notion of provider impairment, which is what Tom is referring to, is actually not that, it's not that recent, but it's taken a really long time for it to become recognized. And I also think there's still a lot of stigma that a lot of us face in terms of acknowledging the fact that this work does have potentially negative impact. And I also think, if I back up a little bit, years ago, I'm in Kingston as well. And years ago, I was a mental health professional in the community. And part of the folks that I saw were medical residents. I was kind of like the go-to therapist in town for medical residents. And again, I saw a lot of fear and stigma around acknowledging that this work might actually have negative consequences, that somehow it was either, you're not cut out to do it. I heard a lot of suck it up buttercup, particularly among nurses. And early in the field, I particularly started becoming concerned because I was noticing service providers around me really exhibiting a loss of empathy. And I'm sure you can all think of, if you've ever done, rotations where you see some incredibly compassionate providers and some who really seem to have lost their care and consideration for each other or even for their patients. And so at the very beginning, I became interested in all of that. And on top of that, I was a trauma expert and I had no tools, none whatsoever. I was totally flying by the seat of my pants. I didn't have tools to help people. So basically, there's a lot of terms out there, but where we've landed, like today, is, and actually maybe Tom, this is a good time, if you don't mind showing our Venn diagram. I think it gives like a really good visual. And as we show you the Venn diagram, it becomes a tool that you can all use right away to try and kind of understand what's going on for you. And the way the Venn diagram goes is you'll see there are basically overlapping circles. Perfect, thank you so much. And I'm gonna very briefly go through each one of them because this is not just a conceptual framework, it's actually a way for you to assess how you're doing right now. I like to give it the pandemic twist because that's where we're at. We're all in the soup together right now. And the way to think about it, if you think about the pandemic or normal stressors, is to start with the top one, the personal circumstances, and kind of go through and assess for you individually right now, how are you doing? And of course, personal circumstances are incredibly complex. We all have lives, we all have situations, whether it's family, relationship, caregiver roles, and that's going to change at different times of your life, as I'm sure you can agree. Tom and I have children in our lives. Tom's has a child where there's been homeschooling because of, COVID. I have older kids, but when I was raising them and I was doing crisis work, how do I manage that? Some of you may also be, just dealing with life, our history, our vulnerability, all of that. So personal circumstances might be that you're really well right now, or that you are incredibly stressed by all of those things. And then when you keep going down the circle, and by the way, you can also use this as a tool to develop some empathy for your colleagues. I know that currently, for example, I have a lot of friends who are in the sandwich generation where they're caregiving for vulnerable relatives. One of my friends' father just got diagnosed with COVID. He's 80 years old. He's in a nursing home. All of those factors have an impact as well. The next one is work-related traumatic grief and loss. And you can think of that one in two ways. You can think about it as real solid grief. You lose a colleague, a patient dies, a traumatic event that really has an impact on you. But I don't think we talk enough about small L losses. And small losses would be, you lose a beloved colleague because they retire, because they're fired, because they're moved, because your agency gets merged with another one. And also with the pandemic, all the little rituals we no longer have access to. So when Tom was talking about, the dinner where we met at the university club, all of those ways of connecting, having a glass of wine, having a glass of soda, whatever, sharing a meal, all of the ways in which we connect with each other are no longer available right now. The next one is called direct exposure. You may also know it as primary trauma, and it's something that we all understand. For example, we all agree that first responders have direct exposure, where they may be a witness to a direct event. But I think we often forget that a lot of other healthcare providers have direct exposure, whether you are a witness to an assault, whether you are in surgery at a very complicated surgery with a bad outcome. I mean, there's a million ways to think about how things impact us directly. And the way to think about direct exposure is if I am at the crime scene or I witness a crime scene, that's direct. If I go home and I tell my best friend or my partner every graphic detail of what I smelled and saw during that crime scene, that can become indirect or vicarious or secondary. You can use those terms interchangeably. It can become an indirect trauma exposure. And the thing about vicarious or indirect trauma is that it can really hitch a ride with us. And I'm sure all of you, if you're newer in the field, if you're like me, at the beginning, I had this passion for gory details because it's interesting. Let's be honest, it's super interesting. And part of what we would also find is that we would seek those, we would then kind of slime each other like, that's nothing, wait till you hear what I saw, But then what we might also do is go home and watch, 7 episodes of Breaking Bad while, eating potato chips. And what we're realizing is we're not letting our kind of brain reset. But what we also started noticing over time is that the indirect exposure can really alter your sense of the world. Now, in the interest of time, I'm not going to give details for every one of them, but I'll give you one really quick example from my own experience. Because I do a lot of crisis and trauma work, it altered my sense of my children's safety. And so I might be suspicious of, my son's soccer coach because I work mostly in child abuse. And all of a sudden I'm like, I don't trust anybody. Or when my son started driving, and Tom knows this story, I had worked in a hospital emergency ward, so I knew all about motor vehicle accidents. And when my son started driving on the 401, he goes to school in Hamilton, I was so panicked about his risk factor that I actually hired one of Tom's friends, a retired police officer who's an expert in tactical driving, to give my son tactical driving lessons on the 401, because I was convinced that, and as an aside, I think everyone should do that, but it just kind of shows you that my work had really altered my sense of safety. And we can notice that at times, or we become just really preoccupied with certain stories more than others. Vicarious or secondary trauma left unchecked can really contribute to significant provider impairment. It can be mild. It can also go all the way to post-traumatic stress disorder in worst case situations. The next one is empathic strain. It's the term that you probably know as compassion fatigue. The term is being replaced because the belief is that empathic strain is more accurate. And that's what I talked about in my TED Talk. If you ever want to watch it, or if you saw it, it's really that emotional and physical exhaustion we develop over time. And Tom and I have talked about this a lot, that there's certain types of patients that are particularly exhausting. Either they are, and I don't believe in these words, but I'm going to use them anyways. I think these terms are unnecessarily judgmental and blaming, but you've all heard the word non-compliant, resistant to treatment, borderline, manipulative. Why would we use words like that when in fact the reality is most of those people probably have really complex life events, childhood trauma, live in all sorts of adversity, but we become exhausted because we feel like we're working harder than them. The other thing that we develop is empathic strain at home. So we might still have a lot of compassion at work, and then we go home, and I don't know if you've ever had a friend who has a crisis and you're like, are you kidding me right now? Like, I'll tell you what a real crisis is. I have nothing left to give to you. The next 3 are really complex in terms of their reality because they don't have that many personal solutions, but they are such a huge impact. And it's systems failures. And systems failures is all of the ways in which the system fails you or your patients. This is where you can really develop moral distress when you profoundly disagree with a rule, regulation. During COVID, I know that a lot of people have talked about You know, for example, critical care, who do we intubate, who do we not? How do I feel about that? What are your thoughts about slow code, morally and ethically? There's a million things. And when I do workshops in hospitals, so when I do grand rounds, for example, I always have a lineup of healthcare professionals who come and say to me, all the things on the right are fine. I want to talk about my hospital and what a jerk they are and the systems. And, you know, and I totally agree. Those are complex issues as well. The final two, working conditions is where I believe burnout belongs, because burnout is actually related to your working conditions, your hours, your pay, your rewards, your recognition, who you immediately report to. And research has shown that what matters the most is not where you work, it's actually who you immediately report to. And so if you have a really wonderful attending, preceptor, supervisor, that can make a huge difference. They can protect you and advocate for you and also mentor you. But if you have an unhealthy, you know, supervisor, it can have an impact as well. Of course, also your working conditions in terms of do you have a you know, choice and control over your shifts and your pay and all of that. The final circle, I'm in Canada today, so I can speak freely. I'm going to tell you right now, the truth is that we added the social cultural factor when Donald Trump was elected. I'm just being totally honest. And can I just say, woo, anyways, yesterday was a phenomenal day in my stress hormones, but we added social cultural factors because a lot of people I work with are themselves, you know, represent or are members of a group that has been either racialized or discriminated against in a variety of ways. And what they were finding is that they were having a lot of moral distress. Let me give you an example. A lot of people I work with work in the United States with families who have been separated by ICE. How do you deal with that? Let's pretend that you yourself are a Latina social worker, you work in Texas, and you are helping families that are directly being traumatized by things that you also have experienced and you profoundly disagree with. So that's a really big circle. And the idea is basically to kind of take a look at yourself right now and say, which are these are areas of strengths and which are areas of vulnerability for you. Thank you, Tom. Maybe you'll stop screen sharing for a quick second because then I can see my note. Is that okay? Thank you. So Tom, can I actually turn over and ask you a question? And then Justin, at any time, if there's questions, we will happily answer them. So I don't know how you want to do that, but maybe people raise their hands, interrupt us. Is that good? Anytime?
Yeah, absolutely. That works for us. Anybody
Okay.
feel free to comment or ask a question anytime.
So if I don't see hands up, I'll just keep going. Is that okay? Okay, so Tom, I wanted to ask you a question because you work in chronic pain. And I think that everyone on this call would agree that that can be a very challenging population. And one of the things I've heard you talk about in the past is that there are times where you can't necessarily fix them. Like you can't make the pain go away. So what are your tools when you can't necessarily help in the way that they hope to be helped?
Yeah, I always say pain's a four-letter word in healthcare, where it's like, really want to fix the thing and try and help out with whatever the thing is. And pain's a way more complicated experience. So it's rare that I get to, that I can make a big difference, you know, by myself with a specific patient. The biggest thing that I kind of help with is I'm more of an advocate and a coach with them and trying to figure out, you know, what is ultimately driving their experience. And I have the luxury of being around a great team of different professionals. And it's not always on me to have to try and have the solution for them. So I take a great deal of comfort in that. With that, I actually take the responsibility where I also do my best and not just punt them off to be like, they're talking about emotions. I'm the physiotherapist. Go talk to the social worker, because our social worker, as awesome as she is overloaded. And if I can ease that burden off my colleague, I'll do my best to kind of manage that. Pain is really complicated. And, you know, you mentioned the non-compliant, the, you know, malingerers. You know, I've heard the term gomers, which I you know, I feel like our population, at least the ones that I'm seeing here in the pain clinic, they've been everywhere. A lot of them have seen everybody, and they've been made to feel, or some have been flat out told, this is all in your head, that you're making this up. For me, a big eye opener, a big sort of change in my practice was when I started learning more about trauma-informed care. Understanding what, the more I started to understand about this, and understanding that this population ultimately, very simply, they get sicker than the people that don't have that trauma experience. And just understanding that, you know what, they showed up and they came to their appointment today, that is huge. That might have been, and when you start to understand what they've been through and appreciate the stories, the fact that they got up, got dressed, and made it to an appointment is an unbelievable success for a lot of these patients. So that's been a big shift for me, to be able to understand and have a better appreciation about that. So a couple of things, I surround myself with people that are smarter than I am, that I can lean on and try and be a support for as well.
Can I add a piece to that actually, Tom?
Yeah.
And in fact, it's a good moment where in a minute, I'll ask you to show up the window of tolerance, but you made me think about a piece that I think is such an important, I would call it a career sustaining behavior. So I'm really interested in that topic. The topic of career sustaining behaviors is research that's been done to look at people who remain well for a long period of time in their career. So if we back up a second, some of you may have seen some of the results that came out of a study, particularly with the Canadian Medical Association 2 years ago. And the BC Nurses Association just produced a report as well. And what it found was perhaps counterintuitive, is that the rate of what they called burnout, the rate of provider impairment, I kind of intuitively expected it would be after years of service, that it was related to exposure. You know, that by 25 years of service, the nurse was crispy fried and would drag themselves like to their retirement. That's actually not what the research shows at all. So the highest rate of provider impairment are early in your careers. So the CMA, the 2018 report, found that the highest rate was after 5 years of service. So barely getting out of residency for some specialists. For nurses, it was around 3 to 4 years. And so, and anyone who works in child welfare or child abuse, it was actually at 2 years of service. So part of what that suggests to me is that this isn't just wear and tear. Part of it is also being new, needing to learn, lacking skills, lacking confidence and competence. And what, Tom, what you're referring to, and I agree with you completely, becoming trauma informed, without a doubt, saved my career. It was a paradigm shift for me, because all of a sudden I felt more equipped, but I also felt, and I think you're actually alluding to that when you're talking about the style and the shift in your style, that we stopped trying to work harder than our patients. It's like we have metrics, right? If any of you have worked in diabetes education, it's a really good analogy. If you haven't, talk to anyone who works in diabetes education and they'll describe to you this frustration or fatigue they have with non-compliant patients, especially with type 2 diabetes. And they're like, this is preventable. Check your sugars, stop eating crap, move your body. And what's really interesting, of course, is that people are smart and they're not doing that stuff to make you mad. And it's kind of rolling back and trying to unpack what are the barriers for them. And inevitably, you'll find that people who have a lot of barriers to actually complying with, you know, what would be really helpful for them, there's a whole bunch of other stuff going on, and they often have high rates of adverse childhood experiences. That doesn't mean you have to become a trauma therapist, but to me, it changes my goalpost about success. And that's very protective for us as a provider. So Tom, I think it's a good time for us to start talking about the window of tolerance, because I think it's such a good tool for ourselves, but also to understand and support our colleagues and our patients. So do you want to bring it up, and I'll talk a little bit about that, and then you can add anything you want to it. Is that cool? Thank you.
Can you see that?
Yeah, that's a yellow zone. Do you want to move to the window of tolerance with the little sailboats? Yeah, perfect. Thank you.
I did have something to add. Just
sorry,
I
go
like what you
ahead.
said about not doing more work than the patient, and I think another thing kind of just sort of is being able to actually set good boundaries. You know, I used to think I need to work really hard because they're not motivated enough, or so I have to be extra motivated. And I'm a terrible cheerleader. But one thing I'm really good at is being honest and setting boundaries. And I tell patients, I will meet you 49% of the way.
I love that.
I will meet you right there. But it won't be 50, and it's certainly not going to be 51. But I will go 49% of the way with you. So being able to set that boundary, I found has been really helpful for me.
Well, actually, you just made me think of something else I want to add before I talk about the window of tolerance. A lot of the education work I've done is with Dr. Rupa Patel, that some of you know. She's a wonderful physician in Kingston, works at the Kingston Community Health Center and elsewhere. And so she works with a lot of, you know, patients who have some pretty challenging lives. And she talked about how one of the challenges in healthcare, particularly in medicine, is that we are trained to, especially if you're a family physician, you're kind of trained to, patients also, they want a prescription, a referral. Well, that's it. They either want a prescription or referral, right? They don't just want you to say, you should really meditate. They're kind of like, thanks a lot. That's not what I came here for. And part of what Rupa and I talk about is learning to tolerate the fact, and I love what you just said about meeting them, you know, 49% of the way, that you don't necessarily have to have all the answers and the solutions. And that's part of a dialogue where you need to, in a way, educate your patients about managing expectations. And I certainly know that Tom, as also a regular physiotherapist, you know, dealing with, you know, musculoskeletal, physical injuries, all the other work you've done, I know, because we've talked about this many times, that very few patients actually follow through and do all the exercises you told them to do. And then they come back and they're like, I am still sore. And you're like, did you do your exercises? And they're like, no, you know? And so kind of learning that piece as well. So I'm going to jump right in here because I know I'm aware of the time, but I love this. So in addition to becoming trauma informed and kind of learning where I fit on the Venn diagram, I would say this is the other tool that has been a game changer for me. And this beautiful graphic is actually from St. Michael's Hospital in Toronto, now called Unity Health, because they just merged with 2 other hospitals. If you're looking for it, you could just literally, if you put that thing at the bottom, you'll find it online. They have a whole mindfulness program. And it's this notion of the window of tolerance. The window of tolerance was originally developed by a neuroscientist called Dan Siegel. And it's actually intuitively makes so much sense once you understand it. So really quickly, let me explain what it is. So the middle is the optimal zone, you know, where we are when all is well and we're, you know, smooth sailing, kind of the sweet spot. The example I often give is, I don't know if you've ever spilt milk all over your fridge, like all the way down into your vegetable crisper, or you've ever been stuck in traffic, you know, on the 401. And when you're in the optimal zone, you kind of deal with life. You're like, oh, well, that sucks. I was going to clean the fridge anyways, or I'll just listen to my favorite podcast or tunes or whatever. When you're out of your window of tolerance for whatever reason, it might be the final straw that day. So, you know, I joke that, you know, like you rip the door off the fridge, like you go bananas, you have road rage, and that's called hyperarousal, or conversely, you can go into hypoarousal. And hypoarousal, I think we don't talk about nearly often enough. And it's also something that happens to our patients, the ones that, you know, we don't miss hyper-aroused patients because they are raging and throwing chairs around. We miss the hypo-aroused ones. And for hypo-arousal would be, to continue the analogy, is that you are so worn out, you just lie in the puddle of milk, you know, on the floor, and you're like, I friggin' give up today. Or you take your hands off the wheel and you're like, I surrender. The thing that's really interesting about it is, of course, we're going to have highs and lows depending on life, how well rested we are, what's going on. I'm sure you'd agree with me that if I'm driving on the 401 and it's really intense, it's actually really good to be in hyper-arousal for a short period of time. It's going to keep me alive. Can you tell I'm obsessed with the highway? I'm going to stop giving analogies of the 401. But the thing that's really interesting is, first of all, that some of us, depending on our own personality or coping skills, have a much wider window of tolerance than other people. And that might depend on, I'll give you a personal example. If I've had enough sleep, I have a super wide window of tolerance. I can pretty much cope with anything if I've had enough sleep. My partner, it's exercise. If he has not exercised, he has a much, you know, some people get hangry, all of those pieces. So what's really exciting about the window of tolerance is that you can actually widen the window. But finally, what I like about it is it also helps me understand and also not personalize. If some of my colleagues are reacting in a way, we call it flipping your lid, where it's like no big deal for you, and all of a sudden the person next to you is totally out of their window, we can kind of identify that for one another. Tom, did you want to add anything to the window of tolerance?
No, I think you said it perfectly. I love the hyperarousal, really easy to spot, especially when we're talking about patients. The hypoarousal, those are the ones that we tend to label as non-compliant. And, I don't know if you've ever had kind of the experience with a patient interaction where it's just like what you kind of go back and you talk to your colleagues or your classmates and you're like, what do they want from me? What do they expect me to do? And kind of feel like the patients might be in this hyperarousal and they're not sure how to get out of there, and really just looking for help at the end of the day. I think as physiotherapists especially, we love blaming patients for being non-compliant. We love blaming them for not doing their exercises. It's a tough sell. Do this really hard thing over and over again, and fingers crossed you'll feel better eventually. So generally, I find it's a really tough sell on a lower motivated patient. Yeah.
And just to add one piece, the thing that we found that really helps widen the window of tolerance, and we know now we have so much neuroscience, is mindfulness. And mindfulness doesn't necessarily, and I know we've talked about it ad nauseum and people are like, enough already. Mindfulness does not have to be 40 minutes of meditation. Mindfulness can be we have a whole bunch, we'll share with you at the end, we have a whole bunch of free activities on our website. They're all on our COVID page, but it can actually be a 3-minute breathing space. One of our colleagues, Diana Tickes, who's a social worker at Hamilton Health Sciences, has developed during COVID an activity she calls PRN. You all know what PRN means, but for her, it's pause, reset, and nourish. And so there are ways where we don't need to wait till Friday and collapse on our couch, to take care of ourselves. We can actually do it as a moment-to-moment process throughout our days. And there's a lot of literature around that. Before we keep going, are there any questions so far? Are we going the right direction? Like, ask us anything you want. What are your thoughts? Justin, do you have any thoughts, reactions, questions?
I know that, I'd heard you talk about the breathing activity before, and you also mentioned that there were things, I'm sure you're going to get into this as well, but things that you could do kind of moment to moment to refresh yourself. I mean, from patient to patient, I'm sure as the day goes on, these things kind of add up. So if you could just, I guess, go a little bit more into how we can do that a little bit better or integrate that into our daily practice.
Let me share some micro skills with you right now. I think we all need them, right? We need micro skills. Excellent. Yeah, so there are actually a lot of, so let's back up a little bit. One of the things that we know from neuroscientists is that the reason, for example, why does mindfulness work, right? Because we know it works. It's actually one of the few things where we have randomized control trials that show that mindfulness reduces what was called at the time compassion fatigue. We have full RCTs. And part of that is that it's a practice. So anything I'm going to talk about, it's not just like, oh, I tried it twice, it didn't work. Usually they recommend that you try these practices for 4 to 6 to 7 weeks regularly before they actually have benefits. But there's some really interesting fMRI studies that are now showing that they really do have an impact, and they can be really, really simple. So what's the goal of these practices? What we're trying to do is train our brain to be here. So I'm going to give you a very silly example, but I'm sure you've all done it. You all wash your hands 1 million times a day, right? And we always should have, by the way. Good for us. We're finally doing it. How are you washing your hands? Are you washing your hands by, while ruminating about the past or worried about or anticipating the future? I would suggest that most of us do, right? It's very rare that we're just washing our hands. We're kind of like, okay, what do I have to do next? Or that person really pissed me off. What was going on? These are micro moments where we can literally, and I'm serious, like just wash your hands, feeling the water on your hand and the suds. And what those are, those micro practices, the more you do them, the more they are truly training your brain to be here. But what's been found to be effective is then you need a 20-second pause before you move on. 20 seconds, a pause before you move on to the next thing, because that allows actually consolidation of that practice into your day. So one of the things that Diana and I are working on is teaching people the fact that we've seen so many people wait until they have a holiday. How many of you pre-pandemic, you finally like white knuckled it through, you know, your semester, you finally went off, and the first thing that happened to you is you got sick, correct? Right? Because we're all living on cortisol, and all of a sudden we slow down, and of course our immune system was totally, you know, cracked. And so what we're finding, and this is again from research on career sustaining behaviors, is that whatever you do on your time off, good for you. Self-care is not actually as effective as we used to love to have believed. It's great. I try to eat healthy. I try to exercise. I try to sleep, all of that. But what makes a much bigger difference is what are the ways in which you are doing your work? Are you present in the moment? And I just wrote a foreword to a book that's coming out in a year. So it's ridiculous to tell me about a book you can't see because it just went to press. But it's a book by my colleague, Brian Miller. And he's a real, forgive my expression, but he's a shit disturber. You know, he's a disruptive thinker, and he likes to break homespun truth. And what he says is, he said, what we need to do is actually prepare to have our hearts broken. And what he means by that is there's so many of us who used to think that the way to do this work was to put on a shield, have a hazmat suit. I don't mean a virtual shield, wear your shields. But we used to kind of think that we needed a virtual hazmat suit not to be affected by the pain and suffering of our folks. So let me give you the kind of psychological background to that. The hazmat suit to protect ourselves from people suffering is actually called avoidance. Now, if you're going to go back to abnormal psych, remember abnormal psych 101? The number one feature of post-traumatic stress that has the most negative outcome is avoidance. And so it turns out, I'll give you a background. So a lot of work I do is with child abuse investigators. And I had an investigator say to me one day, you are taking away my armor. You are suggesting that I feel things. That doesn't work for me. I want to feel nothing. And then I want to go home and watch 9 hours of football and drink a 6-pack, right? And understandably, you probably know homicide investigators have one of the highest divorce rates of any profession. So it turns out that avoidance is not actually a technique to be able to last for a very long time. It's okay to feel things. Part of feeling things, though, is being able to notice them. Wow, that story really got to me. This person is really frustrating me. What's going on for me? And finally, having a place to talk about it, right? And this is where I go back to my conversation earlier about stigma. Why is it the belief that somehow we're not affected by that? That's not true. And if we go behind closed doors, I mean, we know, look at the rates, you know, lawyers in Canada, 50% of lawyers in Canada abuse alcohol on a regular basis. I go and I present to Crown prosecutors and they're like, we're immune. This stuff doesn't bother us. And I'm like, respectfully, I disagree. So that was a super long rant about all of that. Tom, did you want to add something? I also see there's a comment in our chat.
Yeah, I'll let you read the comment. The avoidance piece, when we talk about patients with avoidance, you know, I equate to avoidance as like the utilities bill when it comes in. It's like, oh, strong emotion, utilities bill. I'm just going to put it over here and not deal with it and not think about it. What happens next month? Twice the bill comes in and I just keep putting it aside. Ends up being a much bigger problem. You know, we can avoid it for so long, and I get it. It's an important go-to strategy in the moment, because you need to either go to the next patient interaction or you need to get through that particular situation, but not a long-term solution. The more we avoid it, especially when it comes to really strong emotions, if you think that you have this armor on, and I can relate to that guy because I proudly wore it, but those strong emotions kind of sneak in. And what we know about this, and keep in mind, this is the physiotherapist talking about emotions right now. When we can correctly identify the emotion, actually decreases the suffering, which is a really important thing to understand. And I'm getting a little bit resentful with the term mindfulness, just because it gets so overused.
Yeah.
It's not to achieve some blissful nirvana state. It's about being able to identify, recognize what's going on, so we're not getting pushed around by this stuff. So taking that moment to check in while you're washing your hands to say, that was a really tough interaction. I got to go enter this next one. I don't know what I'm going into. Maybe I need to go talk to someone and debrief so I can put that in its place and give the next patient, my best self going forward.
Tom, I want to add a piece. Actually, you just made me think of another tool I found incredibly effective during the pandemic. So some of you are familiar, and if you're not, I'll explain it. Maybe familiar with polyvagal theory. So you all know about vasovagal syncope, right? Remember that? Okay, so basically the vagus nerve, and just a refresher for some of you in neuroanatomy, the vagus nerve was discovered by Darwin, right? And it is the 10th cranial nerve. And if you look it up, it goes obviously from your brainstem, and it goes around your vocal cords, around your throat, around your heart, respiratory system, and all the way down to your digestive system. And with the vagal nerve, its job is basically, there's two, I keep saying vagus and vagal. I'm French, en tout cas. Le vagal nerve, là, basically it is involved in what we call parasympathetic recovery. And so what it is basically, let me give you a simple example. Have you ever received a really horrible email or text that you had an instant physiological reaction? We've all had that, right? And sometimes we call it the dopamine drop, where it's like, woof, like literally either your throat constricts or your gut. We know some people, they get really flushed right here when they're upset. Other people, it's actually, they get teary or their gut, you know what I'm talking about. So that experience, so if you simplify that, so you get the horrible email, you have a physiological response. First of all, let's unpack what's going on and think about how to address it. What's happening is you're experiencing a fight or flight response, correct? Your body is like, oh shit, what do I do? And normally we can usually handle those things pretty quickly. Either, in this instance, I would personally turn to someone else and verbalize it, right? Connect socially, that will bring me down. Some of you will go into fight mode and craft a really salty response, send it off, and then you're like, oh, I shouldn't have done that. It was kind of your fight mode. And sometimes if you're truly overwhelmed by what's going on, you might dissociate. There are some cultures, you might be familiar with this, where fainting is actually a very common way of reacting to strong emotions. It's called ataques de nervios, and it's basically people have syncope. They just check out. So the way you can activate the vagus nerve is the following. So parasympathetic recovery is simply your body trying to bring you back to baseline. And you can do that through all of the things I just described. Activate your vagus nerve, which is basically here if you locate it somewhere. I don't know where because I'm not a neuroanatomist, but somewhere here. And so you can do that might also be through Zoom, but making eye contact makes a really huge difference. So making eye contact with someone else, humming, singing, or whistling. Remember I said the vagus nerve goes through the vocal cords. So my boss actually, when I worked at Queen's University, I always knew when he was stressed because he would walk down the hallways whistling and jiggling the change in his pocket, which were like self-soothing activities. And what he was actually doing is activating parasympathetic recovery. So humming, singing, or whistling. The other one sometimes are tears. And I often think we give people a tissue too quickly. Like if people are having tears, we often kind of give them a tissue right away because we kind of want to comfort them. But if you think about it as actually a neurological resetting, it's okay. And I personally know that when I'm really angry, I get tears, and they're not the same tears as when I'm sad. And I hate that because it feels very disempowering. Another one that we can use very easily is breathing, but in a very specific way, super easy to do. What's been found to activate the vagus nerve are 4 deep breaths in a minute with an emphasis on the exhale. So the longer your exhale, so longer exhales than an inhale, 4 breaths, what it also does is it actually lowers cortisol. The final one I want to mention, which is available to all of us, even if we're on Zoom, is called resourcing. And resourcing is calling to mind a beloved being, creature, human, doesn't matter. So for example, if you have someone you love and you cherish, calling them to mind. My daughter got a cat I don't even like cats, but I'm insanely in love with this kitten. It's embarrassing. I don't know why. It got me. His name's Gary. He's got an Instagram account. Like he's super famous and adorable. And literally, I'm not kidding, thinking about that little furry creature when I'm stressed or even looking at a photo will actually bring parasympathetic recovery. So folks, those are things you can do in between seeing a patient because they're so portable and available. And the last thing I want to mention is you're hearing me use, kind of some neuroscience to back it up. I never really understood why my mindfulness worked. And like you, Tom, I got kind of fed up of hearing everyone say it. And so what I needed to do is understand the neuroscience behind it. And when I know why something happens, I'll give a last example. We've been talking a lot about the COVID fog, right? So I don't know if you found this, but chronic stress really has impacted me in terms of my short-term memory, increased cravings of comfort food, difficulty sleeping. Like the pandemic, I've really noticed that cortisol, that increased stress hormones have had an impact on my day-to-day, kind of more brain fog, being tired earlier. But when I understood that it was related to stress hormones, all of a sudden I was like, oh, well, I know how to manage that. So I like to have, some data and explanations. Comments, questions?
I know one thing that oftentimes people struggle with is that sort of fine line between avoidance and self-care, relaxation.
Yes.
One thing, it's like, yeah, I feel like self-care, I'm going to watch a serial killer documentary for 12 hours on Netflix as my self-care. Kind of really, that's what I talk about mindfulness being overused, but what's really important is really kind of checking in and taking stock of, what am I doing right now? Am I avoiding, or am I actually doing my self-care? And there is a fine line. And comfort and relaxation, I think, are different things as well. So to really get that parasympathetic response, a really true relaxation response, to get us out of that sympathetic overdrive, I find a lot of people kind of mistake comfort for relaxation, right? So watching serial killer movies and eating chocolate cake at 2 a.m, very comfortable, when I'm under my blanket, but not feeding that parasympathetic system. I'm not getting a relaxation response by doing that. So kind of being able to differentiate between those things are important.
Tom, I'm laughing because I have a study for that too, if you want to hear it. So I have a neuroscientific study for that one too. So I should disclose, my husband's a neuroscientist, so we talk about this a lot. So a couple of years ago, I was working with the Parole Board of Canada, and so they were dealing with the paroles and clemency division. So they were dealing with really difficult cases and making really difficult moral and ethical decisions about should these people receive a pardon and what have you. And unlike the United States, you can't just write that with a Sharpie on a napkin and have everyone, forgiven in a day. I'll stop my political comments. So the boss said to me, she said, listen, I have a concern that one of my parole officers, probation officer, is playing Candy Crush between clients. And she said, I worry that that's not actually restorative, but I want the science. She said, I don't believe that's restorative, and I want to know why. So here's the study. So a couple called Kaplan and Kaplan in 1989 wanted to understand that. And the question was, some of you may play video games, or you like going on TikTok, or you like going on social media. And as Tom was saying, it's really interesting if you observe for yourself. I can do some of those things for a short amount of time, and it's exactly what I needed. And when I do it in excess, it's actually a form of numbing out, and I don't feel restored at all. So I wanted to understand why that is. So what Kaplan and Kaplan found is that there's a really big difference between directed attention and unfocused attention. So directed attention is I'm playing a video game and I'm fully concentrated on the video game, or I'm watching, the serial killer show and I'm completely absorbed by it. And that is actually not a restorative practice, because your brain is not actually getting a break. It's actually fully concentrated on the task at hand. So I think what's really good about that is knowing that. So like you, Tom, when I make the decision I totally have binge shows as well, but I make a decision saying that's what's going on, as opposed to having Netflix say to me, are you still watching? Does that make sense? It's kind of like being aware and understanding what's restorative and what's not. And if you commit to the full Tiger King series, go for it, but know that that's not necessarily a restorative experience. Those are my thoughts about that. Any other questions?
That's amazing. I think a lot of us have definitely binged on Tiger King at some point or another. But I know you were talking about, avoidance techniques for ourselves as the, therapists or healthcare providers. How would you break that down to patients who you think are also doing those same practices? And maybe Tom can field some of this question as well, because I would imagine that would also maybe add to their hyperarousal, going back to those 3 ships that you were talking about. So how do you break that down, I guess, in layman's terms, for lack of a better term?
Tom, do you want to take that one?
Yeah, I use the bill analogy. I feel like is a really good one. Or another one that I've heard is kind of like the beach ball analogy, when you're trying to push it down underwater, and the further you push it down, the more pressure builds up to ultimately kind of slips, and then it goes shooting, 100 feet into the air. So I use a lot of analogies that way. And what I find kind of in my practice is doing a lot of this education in a group, especially with chronic pain patients, I find really helpful. Someone will have an experience that is similar to what you're describing, or when you kind of ask them, who here, do you think who here has ever avoided? Françoise talked about, when Netflix asks you, are you still watching? A couple of heads will be like, yeah, I've seen that screen plenty of times, right? So I think if we just ask the question, have you ever had an experience where you've been avoiding? And I would bet that we've all had done it at some point. And I think not to stigmatize it as being a problem, because I 100% get it. It's like, why do I want to be in a moment that's really crummy, right? Why do I want to be in a terrible, why do I want to be more present in a shitty situation? Right? Why is that? How is that beneficial to me? Avoidance is and it's a natural response to a tough situation. It's just not, so having to demonstrate that it's just not a solution for long-term success or long-term health. And being able to identify, because that's a big question I get. It's like, when my avoidance go-to move is the same as my self-care move, when is it that one thing and when is it the other? Which makes it really tough. And I kind of go back to the mindfulness thing. The more mindful, the more we get to check in, the more we start to explore kind of the thoughts and beliefs that we have, and being able to check in with that, you start to ask yourself these questions, and the more you'll be able to answer those for yourself. I say, I don't exercise because I want to fit into a certain pair of pants, or I'm going to be on a cover of a magazine. I do it so I sleep better at night, and I'm less of a jerk to be around the more exercise I get. Mindfulness is kind of a similar thing. It's not to put you in some blissful thing. It's just so you're better able to deal with the things that happen throughout the day.
Tom, I want to add a couple of pieces to that, if I may. So if we go back to the window of tolerance, I work with a colleague in Los Angeles. Her name is Elaine Miller-Karras, and she works in refugee camps. And she actually she's plasticized the window of tolerance, and literally it's just like 2 bars with a circle, like really simple. And she's been able to educate people in refugee camps through an interpreter and educate them about the window of tolerance. And she said it crosses all barriers. Everyone understands it really quickly. And then she teaches them really simple tools to understand when they're out of their window. And so I just wanted to mention that because you reminded me of that. The other thing I like is from a dear friend of mine. Her name is Laura van den Lipsky, and she's one of the best writers on the topic of secondary trauma. She wrote this, she actually has 2 great books. One of them is called Trauma Stewardship, and the most recent one is called The Age of Overwhelm. Could not have been written better. And The Age of Overwhelm is full of really simple, accessible neuroscience tools to reset and kind of before, during, and after exposure. So if you're looking for one book, The Age of Overwhelm is the book, in my opinion. And Laura has a great way of saying it. She's a social worker, and she has a great way of saying it. She calls it the check me out situation. And so check me out is self-awareness. She'll be like, check me out, watching 7 hours of Netflix right now. And what I like about that is that, as Tom was saying, there's no judgment. This is not about beating ourselves up or losing compassion. It's kind of like, look at that. Look at me feeling terrible or being a bear because I didn't exercise. And so I love that language now, because we're kind of moving away from prescriptive, In the military, they started, mindfulness wasn't a popular term, so they started calling it combat breathing or tactical breathing. I'm like, it's just mindfulness, guys, but whatever. So it's okay not to get kind of hung up on that. I personally am never going to meditate for 40 minutes a day. Like, I know I'm just never going to do it, but I can definitely do 3 minutes. And it has been an absolute game changer for me, for sure.
That's amazing. And so just kind of being cognizant of everyone's time, I could sit here and ask you another 20 questions, I for sure, absolutely. But I'll open the floor up for one last minute. If anyone else had any questions, T-10. But otherwise, I'd just like to say thank you so much for this talk. It's been super informative, and just judging on, you know, the wide variety of medical professionals that we have here, I'm certain that a lot of these, you know, tools and tidbits of information will be helpful, not, you know, a few years down the road tomorrow for different people to be used immediately. So definitely appreciate the actionable items. Those are amazing. We'll go back and hopefully in this recording, one of our team members will be able to kind of tag some of the references. As much as there've been so many different references, we'll tag a lot of them, or maybe I can get in contact with either
Please do. Sorry about that. I tend to do that a lot. Email me and I'll send them to you. You know what I'm going to do, Justin, real quick? I'm going to put in the chat. If you go to our website, you can find the free COVID-19 resources. So you click on resources and then click on COVID-19, the big button. Everything behind that portal is free, and there are tons of things that we talked about. But email me and I'll send you all those ridiculous long list of things I named.
Not so ridiculous. No, we'll definitely be able to put those things in practice. But again, yes, thank you guys so much. And we appreciate it. And I think that will do it for January's speaker series. So stay tuned, guys. This will be recorded and put on our website. And thank you so much for joining us today.
Take care. Bye, everyone.
Bye, everybody.
Thanks.
Just one more thing before everyone leaves. If you could just fill out the feedback form that we have for future talks, just to let us know what you guys want to hear about next. That would be great for the month of February and future talks as well. And I'll post the links in the chat I just posted. And again, once again, thank you all for coming out.
Sorry, Peter, I forgot to send that to you, or give you a second there. I know we went on for so long. They can definitely hold a crowd with that subject matter, but awesome.
Yeah, no worries at all. It's all good.